Welcome to our webinar titled Living with GvHD, a patient panel discussion. Thank you for joining us. My name is Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to thank the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. You may lose your internet connection during the webinar. If you're unable to view the webinar online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately during this presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. Submit a question or a comment. Open the Q&A window in the lower part of your screen. Type in your question in the small text box window, and when you're finished typing, just hit enter, and we'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your question all at the same time. Second, please do not share private health information in your question. Our speakers are not medical experts and cannot answer any questions related to your health care. Our panelists today, we have Sean and Nikki. So thank you so much for both of you joining us today. We're delighted to have you here. And I'd like to go ahead and start and have each of you introduce yourselves. Nikki, would you like to start?
Sure. My name is Nikki Greb, and I was diagnosed in 2019 in May with MDS, high-risk MDS. Do you want me to go through the questions?
Go ahead. We'll go through those. Just, do you want to do a brief little introduction, okay, and then we'll go through all the questions.
So I'm from Boston, and I go to Dana-Farber for my cancer treatments and follow-up care. I have a husband and 3 kids, and this has been quite a journey, and I'm happy to share it with you.
Thanks, Nikki. Sean?
Hi, yeah, so I'm Sean Cryan. I'm in Seattle, Washington. Seattle Cancer Care Alliance, the Fred Hutch Cancer Institute, and UW Medical Center are the centers of excellence that I have the ability to tap into here. My journey started when I was a kid. In 1967, I started being a research subject with Dr. Weiss at St. Luke's Roosevelt in New York City. He was studying why we were bruising and had longer bleed times, and found a platelet disorder he called thrombocytopenia A, because he noticed we had reduced platelets and we had the function of those platelets that we had wasn't as good. We always suspected that there was a connection between that and AML, because my grandfather and great-grandfather both died of that on my mother's side. And then we were contacted by Marshall Horvitz at the UW Medical Center here in Seattle, who was studying a connection called the RUNX1 mutation. So he was one of the people who published about a RUNX1 familial platelet disorder, which is now what our diagnosis is called. Shortly after he published on that, my cousin at the age of 19 got AML. He had a transplant. And then in 2010, when my youngest daughter was 12, she was diagnosed with AML, and she also had a transplant. She subsequently had secondary thyroid cancer that was also successfully treated. And so I was diagnosed in 2012. I had a transplant in 2012, which didn't engraft, and then I had a second transplant in 2013. So that's pretty much about a year out from that, I started having some issues with GvHD, and so I'm still tracking that to this day.
Thank you so much, Sean and Nikki. What was your diagnosis before transplant? Nikki, would you like to start?
Before the transplant, I had high-risk MDS, and I was given 2 to 8 months to live, and there was no choice. You make the choice whether you're going to go to transplant, and then they start cancer treatments for the 6 months leading up to the transplant. So I chose to live and go right to transplant as fast as I could, which still took 6 months.
And Sean, how about you? What was your diagnosis before transplant?
Yeah, it was similar. I have 3 daughters, and after the first one, after our scare with the first one, we decided to figure out what the baseline was for people with the RUNX1 mutation in our bone marrow. And we checked our 2 daughters, and there were some anomalies there, but they were wanting to get a fuller picture of what that might look like. And so they did a bone marrow aspiration for me, and they said, well, guess what? You already have MDS. And so mine, because of the particular mutation for my MDS, if it advanced to AML, it was also pretty high risk. So that's why we made the decision to go in and do a transplant and not wait. So again, that probably about 6 months to that first transplant. It was in October, and my diagnosis was in March, so a little bit longer. I had to be treated for tuberculosis first before I could go through the transplant process.
Nikki, what led to your diagnosis of MDS? What symptoms were you having that led you to go and seek attention?
So was that Nikki or me?
Nikki, I'm sorry.
Oh,
Yes.
sorry, Dr.
Yes,
Yeah,
Sean.
you were a little quiet when you first come on.
Sorry.
So
Yeah,
yeah.
sorry. I didn't hear
Sorry
you.
about that.
I had just come back from a wedding in Costa Rica, and my stool was just not normal, not the same. So I thought, oh, it'll resolve, but it didn't. So then I saw a gastroenterologist. No, I went to my doctor, and she took, stool sample and had it checked out. I thought I had a parasite, but she says, no, you're fine. So I waited a few more weeks, and then I contacted her again. I said, something's still not right. And so she sent me to the gastroenterologist. And what she did was take a stool sample, but also take my blood. She took my blood, and she called me immediately. She says, I am no longer your doctor. You need to go to a hematologist immediately. You do not stop. Do not, collect your $200. Make an appointment right away. It still took a week, but I had pancytopenia, which is low white cells, red blood cells, and platelets. So that's what I did right away. Went to the hematologist. And the hematologist said, I'd like to take a bone marrow biopsy. And I said, sure. I had never had one, didn't know enough to run out of the room screaming. No. I've gotten used to them. They're not so bad. But she did one right away that day that I came in, and that biopsy proved to have the mutation, the TP53 mutation, which put me in high risk, and some others. I just don't know those off the top of my head. And after I saw her, I did go to get a second opinion. So I first went to Beth Israel, and then I went to Dana-Farber for a second opinion. I could go on. I don't know when you want me to stop, but.
Thanks, Nikki. And Sean, you kind of alluded what led you to your diagnosis. Anything else you'd like to add?
No, I mean I think it was about between 20 and 25% of my marrow cells showed evidence of MDS at the time of that. There was some discussion. There was a lot of discussion about when was the right time to go to transplant for me, because they didn't have a history. They hadn't tracked it at all to know, how rapidly it was developing. But ultimately, it was that because it was, a fairly dangerous mutation if it got to AML. That was what finally convinced everybody that just like Nikki, it was better to deal with it now and not let it get to be something that would be really difficult to treat.
Sean, did you seek a second or third opinion regarding your diagnosis and your treatment options?
Well, so one of the things about some of the treatment centers, I'm not sure about all of them, I can speak to SCCA, is that they do, the doctors within the organization actually share information back and forth. They even have the Wednesday meetings where they compare notes, or they'll bring up particularly difficult cases for discussion. So I was a Wednesday topic more than once. And so that kind of gave that the idea of a second opinion kind of is a very team-oriented process. So it wasn't a single doctor that was, trying to get an opinion of a different single doctor. It was the medical team there that was trying to do assessments. And there were disagreements even on the team. Joachim Deeg thought we should wait, and he knows a whole lot about MDS and AML. But there were enough other doctors that really understood my situation that thought, yes, that it was the right decision to make.
Nikki, you mentioned about seeking a second opinion. How did you go about that? What did that second opinion do for you?
There are a number of soft things and hard things that changed my mind about which place to go to. And the soft things are, we drive an F-150, my husband does. And so it was extremely difficult to park at Beth Israel. And that was the very first thing that was just so difficult. I really liked the doctor I got. I really appreciated her. It was, the whole operation at Beth Israel is smaller. So, there's not as many people. There's only one person helping you park your car. There's only one person doing the intake and and when you're leaving and that part. There's one person drawing your blood, and then we went to Dana-Farber, there is a fleet of people parking you. There is a fleet of people taking your blood. There is an extraordinarily streamlined process of getting you in and out of that facility. They have the store, they're just geared towards people with cancer, and that made it so much easier all around. I think the doctors would have been of the same caliber. Although, like what you said, Sean, at Dana-Farber, there's a team of people making all their decisions. And I don't know about Beth Israel. I actually just don't know. I didn't get that far with them. So I did end up going to Dana-Farber.
And what was the ultimate deciding factor to go to transplant and not try other options? Nikki, would you like to start with that one?
Yeah, I had no choice. I was either, I had 2 to 8 months to live. I was told, go home, think about it right now. If you want to live past the 2 to 8 months, you have to go to transplant. There is no choice. There was no choice for me. And I, of course, there's no choice. I was going to try to live. They did say, it's not a guarantee. Going to transplant is still, you have a 25% chance of making it through the first year after a transplant. And so it's not a guarantee that you're going to live, but right before the transplant, they offered me a clinical trial with a venetoclax component, another drug. And they said that would up my chances to 50%. I said, yep, bring it on. I'll take anything to live, So fast forward 1.5 years, I'm still here, and I am extremely grateful to be here. So yeah, the choice was go to transplant or go to transplant, really, for me. So
Sean, how about you? What led to your ultimate decision that transplant was the right thing for you?
Well, I mean, part of it was the seriousness of it. If it became AML, also I have some underlying medical conditions related to my lungs and my heart. I actually have an artificial heart valve that actually the artificial heart, I had a heart valve repair prior to transplants, and then post-transplants, I wound up getting an artificial heart valve replacement as part of that. But the general feeling was that if we went early too, we could do something called a mini transplant or a non-myoablative transplant. So it was a less rigorous, less toxic preparation for transplant than what my daughter went through or my cousin went through. My daughter, for example, for her, the radiation prior to transplant, she had 12 gray. And I had, in the first transplant, I had 3. And in the second transplant, I had 4. So as an adult male, I had, you know, almost a little bit more than half total radiation for 2 transplants is my 12-year-old 100-pound, not, well, at that point, no, she was about 70-pound. She's about 100 pounds now. Daughter had for a single transplant. So there was just that was the other thing, was trying to make sure that I didn't get weakened so much in the time period prior to the transplant that I wouldn't survive the transplant itself.
Thank you. And what were you told were the risks and the benefits of having the transplant? Nikki, would you like to start with that one first?
The risks were still dying. Some people don't make it. Some people, I did slip into AML. My MDS qualification was 15% blasts or immature cells. And at 20% of blasts or immature cells, it's AML. And I actually did slip into that. I can get into it later, but the risks are, the transplant fails. So the grafts, the person who donated their cells don't engraft in your body, and that means you have to go to have more chemo and more T cells and build, a week of this and a week of that, and building up and trying to get back to that. To make the transplant ultimately more, successful. So there's that risk. There's any number of things that can go wrong, but that's, I guess, one of the main things. And yeah, they don't sugarcoat anything. They just they will tell you, everything, things you don't want to hear, but that you really do need to in order to process everything correctly, and help your family process, and your kids and your husband. It's just, there's a lot to it. And if you're going through a transplant, I really highly recommend therapy and talking and learning how to talk about your diagnosis and what can and may go wrong. But as far as your original question, there's so many things that can happen. What I encourage everybody else also to do is just to be really calm and just don't think about all the things that are possible, the negative things that are possible. Think of the good things that are possible, because your body wants to heal itself, and given the opportunity, it will. And I'm still healing today. I'm a year and a half out of transplant now. So it's they try to give you a very realistic view of the whole thing, but I was put in a pretty high risk category, and I'm here today. And I have a lot of people in a lot of support groups that are also here today, and I'm like, wow, this is awesome. So
Thanks, Nikki. And Sean, what did they discuss with you about your risk of transplant, and what were also the benefits they discussed with you?
Well, yeah, they definitely, I agree with Nikki. They talk about comorbidities. It was sort of a newish kind of phrase, comorbidity. But yes, all the other things that can kill you when you're going through the transplant. And they're very upfront about that. And I think they need to be. You need to go in and making a real decision. I was impressed actually by it felt like it was my decision. I mean, I think they present all the facts. They give you all of the possible things that could happen, and then I felt like I was able to make a very informed decision based on what the doctors had been telling me. On the the positive side, I we have, because of our family experience, we kind of knew what the possible outcomes could be. I obviously could see the benefits. My cousin now has 3 kids of his own. My daughter at that point was already back in school and, hadn't even missed a year of education. She was able to keep with her grade when she was going through her treatment, which was really great for us. Um, and and my daughter's first doctor, there's a doctor at Children's, she's Abby Rosenberg, and she said to us the first day is that, sorry, I always get a little choked up about thinking about this, but, she said, nobody, we were talking about, well, what likelihood, what's their survivability rate or whatever. And she said, well, basically every patient is either going to live or they're going to die. So you just go in assuming you're going to live, and that really, I think that stayed with us kind of big time, because you can't, this is the world you have, and so you deal with it. And so that was the positive outcome we were looking for, was that we would get to that living part.
And when did graft versus host disease first become a concern for you? Sean, would you like to go first?
Sure. Interestingly, both my daughter and my cousin had acute GvHD. So they had GvHD that occurred shortly after transplant, within that 100-day period, but then resolved relatively quickly. My daughter's was pretty severe. She was in the ICU. She had got GvHD. For me, actually, my cousin had got GvHD as well. For me, I didn't have any acute GvHD during the early phase, but about a year out, I started having issues with skin rashes. You saw Nikki putting in eye drops. I also started having issues with dry eyes because of the GvHD attacking the glands that are on the underside of your eyelid. Uh, so that it sort of came and went. I was on steroids for a number of years, enough so that I wound up with osteopenia, which was one of the things that they had also warned about. But the most things sort of modulated, and then a couple of years ago, it kind of flared up again. So I now, it's mostly been skin GvHD though that I've been dealing with.
Thank you. Nikki, how about for you? When did GvHD become a concern for you?
Um, the timeline was this: I had my transplant December 27th, and in March, my transplant was considered a failure. And I went in to go to the hospital for a week. I sat there the first morning getting platelets so that I would I had slipped into AML. All of my blood levels had gone down to the depths of where they shouldn't be. And my immature blast cells had gone up to 20%, which slips you into AML. So anything up to 20% is MDS, and then after that it's AML. So the morning I was getting a bag of platelets, the nurse said, "Wow, you have a big rash on you." And I said, "Oh, really? I didn't walk in with one." And they brought in some other specialist to check it, what percentage of my body had this skin rash. And the skin rash is GvHD of the skin, but it also means that your transplant has taken hold and is working. And so it's a blessing because it actually it the transplant didn't actually fail. It ended up resolving on its own, and I was put into remission a couple months later. Like my cells started working. The transplant took hold. Um, my blood levels went up magically, slowly but surely. Like your body wants to heal. I saw it happen just right in front of me. And so the skin GvHD was the first thing that happened. It lasted, it was itchy and it was a rash for probably 2 weeks. And that's all I had of skin GvHD. I know a lot of people get left with it, but I did not. So that was the first thing. Then I went into remission. I immediately got mouth GvHD, gut GvHD. It went down to the nether regions, rectal, vaginal, and then all of those resolved within, the mouth lasted for a little longer, maybe 2 or 3 months, maybe 4 months. Actually, I still have some, but it's very little now. It ran a course through my mouth for sure. But then everything else resolved. And then my eyes got hit at the same time. I'm left with eye GvHD to a greater degree. And now I about a year afterwards, I started getting the lung GvHD. So those are my two main problem areas. And I'm still healing from, those two areas. I don't know that my lungs will ever, they say your lungs can't get better, whatever you lose in your lungs, you can't get back. But I am on a clinical trial for a new drug for hopefully that may help my lungs somewhat, somehow improve the lung function. So I'm waiting for that to happen. Again, it's a process. Your body can't fix itself overnight. So I'm just very patient. And so that, and the eyes, yes, I have eye GvHD. I wear special pros lenses, scleral lenses, maybe you call them. And then use a lot of eye drops. Yeah.
Thank you. We have a couple of questions from our participants, and they'll go to both of you. First, Sean, did you have a related or an unrelated transplant?
In our family, because of the familial platelet disorder, we go with unrelated, because anybody who would be a close enough match likely is somebody who also has the initial RUNX1 mutation. So yeah, it was unrelated. My daughter's also was a unrelated umbilical cord donor.
Thank you, Sean. Nikki, for you, related or unrelated?
I had an unrelated 10 for 10 match. The doctor immediately said, I want a 24-year-old male 10 for 10 match. I said, me too. So yeah, all the related people would be half matches or too old. So I did get a nice match, 24-year-old male from Texas, actually. So.
And another question for our audience is, how did they treat the gut GvHD? Nikki, would you like to start with that first? And then Sean will get you to answer that as well.
First of all, there's a lot of immunosuppressant medication that I'm still on. But so there's a medication aspect to all the GvHDs. Wow. I can tell you, it started in my mouth, slowly worked its way down, and it took a long time. And I think it was just medicine and learning that because of the transplant, I became lactose intolerant. So staying away from lactose, learning how to eat differently. I also couldn't handle any hot sauce, nothing. And my mouth was just too sensitive. My gut was too sensitive. So you have to learn what you can't eat. And then you slowly bring it back. And when I say slowly, this could take months. It might take a year. As a matter of fact, it's taken a year for me to eat hot sauce again. But don't give up. Your body is trying, and it's dealing with a lot. So, and I can feel in myself like, wow, I can eat a little hot sauce now. And yeah, I stay away from the lactose. That doesn't go well still. But yeah, it's medication and learning what you can and can't eat, basically.
Thank you, Nikki. Sean?
So for my daughter, she was already on the sort of, the general like prednisone, the kind of things they have you on post-transplant, just so that everything can establish itself. Specifically for the gut GvHD, I can't remember the name of the particular steroid, but they had it in an oil, and she would take drops so that it would basically go down and coat her throat and then work its way down into her gut. And that they wanted that one to be more of a topical. And so that was something that she was able to do every day.
Thank you. And this question goes to both of you from the audience. What chimerism levels have you both achieved? Sean, would you like to start with that one first?
I don't even know. Maybe you could explain to me a little bit more about a chimerism level.
Yeah, hang on. Nikki, do you know yours?
Yes,
Okay.
I am 100% donor blood now. So
Yeah,
yay.
great.
Yeah.
Yeah.
Okay, yes.
So
Yeah.
are you,
100%.
Sean?
100%. Yeah.
100%?
Yeah.
Perfect.
Yeah, actually, after my first transplant failed, I stopped producing blood cells at all. So I was having to have red blood cells and platelet infusions, well, daily for the red blood cells. And then once every about 3 days for the platelets for several months. I had very high iron levels, so I had to take some chelation drugs later to get the iron out of my system. But they basically were just trying to keep me alive between the failure of the first transplant and then the ability to do the second transplant.
Sean, this question is for you. Did you use the same donor for your second transplant?
No, the donors are anonymous, and they don't, it was not within the time frame where we would have actually been able to communicate with the donor between the first attempt and then the failure. So my first donor was actually a 25-year-old from Germany. My second donor was a 19-year-old, both male, 19-year-old from the DC area.
Nikki, you had mentioned that your transplant, they had considered it had failed. What happened to turn things around?
They cannot explain what happened. And it just did. The morning that I was going to go in for the chemo was going to start the next day, but I needed extra platelets to survive a port placement and another bone marrow biopsy. And as I was getting the bag of platelets, something happened in my body that just caused the blood cells to engraft and take hold and cause that GvHD skin response. They said, you can't have chemo, you have to go home. They said, you can't have chemo when you're having when you have a rash like that, because it's actually also a sign that the graft is working. So I went and saw the doctor a couple of days later, and he says, well, you're still going to need more chemo because you have over 20% blasts in your body, those immature cells, and your body can't get rid of those on its own. So we're going to have to schedule more chemo. And the next week I went in, and he was my transplant doctor, and my oncologist came in like little boys in a candy store. And they said, you won't believe this. Your reticulocytes are on steroids. They drew this little graph on the computer, like your reticulocytes are going up like this, where normally they produce like, 0.3%, and mine were at 5.6%. They took care of everything. Like over the next 2 months, they took care of, I never needed more chemo, never needed more T cells from the donor. And they had never seen it before. I didn't do anything special. I didn't eat carrots or celery or anything. I just, I don't know. I don't know what happened. There's a lot of mystery there. And I don't think they can explain everything. They couldn't explain it. And I don't know why, but that's what happened for me.
Thank you. And we have a question from the audience. It says, did both of you ever hit an all-time low emotionally? And how did you get past that and stay positive and motivated? Sean, would you like to go first with that one?
Sure. I think my all-time low emotionally was when my daughter was actually going through treatment. That obviously is, well, not obviously, but it was a lot harder than my own treatment. I did have some ups and downs. I was hospitalized for about 77 days, I was hospitalized for 77 days in between the two transplants, partly because of the condition that I was in. I had developed some infections in my lungs, and they were doing a biopsy of my lung tissue to try and figure out exactly what that was. And they nicked an artery, and so I bled out into my left lung. So I was in a coma, medically induced coma for a couple of days. And when I came out of that, that was pretty low, because I think that was um, uh, uh, my mortality was definitely something that I thought more about at that point than any time previously. And getting out of it, I don't know. I think we are all very resilient people. You just don't realize how resilient you are until you're there, and so that for me, that's what got me out of it. Was just knowing that there was, I wanted to live. So you do what you have to do.
Nikki?
Yeah, it's not one emotional low. I want to say the there's a lot of little highs and lows um, that are mostly lows. You look in your children's eyes and they're just like deer in the headlights. They're going to lose their mom. My daughter had just graduated. My youngest child had just graduated from college, so I was supremely grateful that she had gotten through college, and that they'd all gotten through college, and that they were a little older. And I took positivity where I could, but it was devastating. The first diagnosis was just, that probably was the biggest shock. Um, but then along the way, there's nothing really that encouraging about, you have a 25% chance of making it through the first year of your transplant. Nothing really encouraging here until you get through it and past it. But I thank Dana-Farber very much. They hand you a therapist the minute you walk in. And I had never had therapy before. What did I know? I thought, what am I going to say? There's nothing to say. Oh, people, there is so much to say and so much to process, and things that, things that are different for each child and you, and for your husband and you, and for your family and you, and for your siblings and you, and what it all means, what it's all, there's so many things to process here, and it's very important that you do, just so you can help yourself through it, help your children through it, and your family through it. Yeah, there's a lot of lows, but you kind of you get used to rebounding, and do use therapy, talk all you can, learn skills and things that you can use to get you out of those tough times.
And I would like to just add,
Sure, go ahead, Sean.
yeah, I mean, for me, I think the loss of control was probably the thing that affected me the most, because you feel, you get to a certain age, and you feel like, well, yeah, I can handle what's going on and things. And when you're in a situation where it doesn't necessarily matter what it doesn't feel like it matters what you're doing. That I think that's a really hard thing to go through. So I also focused on, well, what are the things I can control? And that helped me as well. I'm a bicycle commuter, although the last year and a half has been really hard since I'm working from home, and it's not easy to bicycle from, to the dining room. But so when I was in the hospital, they did find me it was just a stupid little thing with two pedals on it. And just being able to sit in a chair and do that, for a couple hours a day made a huge difference. So yeah, I agree, talking with other people is great. And then finding something that you you feel like you have some control over, I think was also really helpful for me.
Nikki, this question is for you. It said, did your transplant team have any discussion or concern about you using a male donor?
No, they told me that a male blood cells are stronger. That's what they said. That's why they were looking for male blood. I actually subsequently, very recently, thought I had, if those are stronger cells, does it give you stronger GvHD? I actually don't know the answer to that. I'm wondering. It also means that those cells help me recover from the slipping into AML. And so, maybe you do want stronger cells so that you can survive, and that they will engraft better. Although, I only have myself as a petri dish. I have no other family members that have ever had this. This is not a familial thing at all. It's nobody knew anything about it. Nobody had ever heard of it. We were all just trying to scramble and learn as much as we could about the medical side, and then also about the emotional side. There's a lot of how you process death. You're not processing death, but you're going through those same stages, like the anger, and the acceptance eventually, that you have to be, that if you're aware of them, you can work through them and help yourself out that way too.
And how is your medical team currently monitoring your GvHD? And are they monitoring you for GvHD that has not occurred or potential GvHD? Sean, would you like to take that one first?
Oh yeah, at Seattle Cancer Care Alliance, they have a long-term follow-up group. And typically, you would see them at the end of the first year, and then I think annually through 5 years, and then after 5 years, it's like every 10 years. And the Be the Match organization has great documents that that you can get that will show you the things to look for and what the common types of GvHD are. I have the benefit of living in Seattle. There are a lot of patients that go through that live in other areas where they have to educate, their local physicians in what to look for and stuff. But because I continue to have GvHD and I have ongoing treatments for that at SCCA, I get seen a couple of times a year, and they're unbelievably thorough, especially for the skin stuff. They check everywhere. They look at everything. I've had issues with all these things, you sort of forget all of the things that have gone through. I had issues where the muscle fascia were tightening. And so that was something that they check for pretty rigorously as well. That was happening mainly in my calves. But and it's happened around my feet as well, so that the feet motion and isn't as fluid as it would normally be because the muscles are tight. So they check for that. But yeah, I am a firm believer in the long-term follow-up and staying current with that and making sure that somebody is looking at things. On the other hand, my daughter, after she did the annuals and I guess she did do a 5-year checkup, she's had to go back in for a couple of things again because she developed a secondary cancer because of the treatment. But really, she doesn't have to see them at all anymore, and there was no evidence of any GvHD beyond her initial stuff during the transplant.
Thank you, Sean. Nikki, how is your team monitoring you and for your current GvHD? And are they also watching for any other forms of GvHD that may occur?
First of all, I think my doctor, the transplant doctor that I see regularly, asks me how I'm doing, how's the mouth, how's checking for the GvHD. But I highly encourage you to educate yourself about GvHD in general, about GvHD in the specific areas you are suffering from it, because your transplant doctor is not a gynecologist, is not a dermatologist, is not a gastroenterologist. When you get GvHD of some part of your body, I encourage you to reach out to a specialist. Your ophthalmologist. I mean, they can only kind of broadly check on you to see if you're suffering from anything. But I have found that in almost every case, I have needed a specialist, because it just doesn't go away without some kind of intervention, either a cream, an oil drop, lots of different things. Now, the ophthalmologist, if you watch the webinars, I highly encourage you to do that. What you learn from them is so vital. I happened to be seeing my ophthalmologist, but I saw the webinar afterwards and I thought, oh my goodness, it's good that we check, because if you don't check your cornea quickly enough, the GvHD pokes holes in your cornea and then you'll need surgery. The sooner you get it looked at, the sooner they can mitigate the problems. So just be aware of that. Your transplant doctor knows things, but they don't know gynecology. They don't know ophthalmology like the specialists do. And if you ever feel any kind of issue breathing or in your lungs, run, don't walk to a pulmonologist, because my transplant doctor didn't know enough to have it checked quickly enough. So again, with the lungs, that's the only GvHD they have no treatment. They have a standard treatment, but there's no cure or fix for lung GvHD. So the earlier you catch that, the better. And the same with the ophthalmology. And if you have lasting problems in any area, you just are going to need a specialist. So, I mean, that is what happened in my experience this last year and a half.
We have a question from the audience. The question is, are either of you on immunosuppressants? Have you been able to mingle with other people? Do you wear a mask? And have your energy levels ever returned to normal? Sean, would you like to take that one first?
Sure. Energy levels, yeah, I mean, probably 95%. Again, I would be much happier if I was biking to work every day. But yeah, I mean, I do all the things that I want to do. Again, this gets into the medical question. Apparently, there is some uncertainty about the vaccinations and stuff. Personally, I have been fully vaccinated. I mask if I'm in a situation where I don't know the situation that other people are in right now, but my wife and I went to the movies and to a soccer match the other night. Yesterday, actually, we won. Sounders, go Sounders. So we've been doing things, but it's my daughter. She is a baker. She works in a bakery here in Seattle, and she has not had GvHD issues and everything, but she's much more rigorous about mask wearing than I am. So I think a lot of that gets to we get some recommendations from our doctors, but there's not a lot of certainty about it. But yeah, prior to COVID, I was at a point where I didn't mask up at all. I don't take any steroids anymore, but I do have a kind of treatment called extracorporeal photopheresis, which is a kind of apheresis where they extract your blood cells, mix them with another chemical, expose it to UV radiation, and then put it back into your body. And it's a different kind of suppression that I don't quite understand what the differences are, but in normal circumstances, no, I hadn't been masking.
Yes. My energy level has been, I thought my energy level has been great all along, but I still see it improving. Like, I don't have a huge amount of fatigue, and I don't feel like I ever did. But I talk to my aunt every day, and she says, "Wow, I can see you've been improving a lot lately." Other people see things that I don't necessarily, but in the last week, I do feel like I've gotten a lot more energy. And I thought, wow, what did I do? What happened? But I think it's just coming along. It's just slowly but surely, I'm feeling stronger. And as far as vaccinations and masking goes, I did get the Pfizer vaccine um, a few months ago, and I had the antibody test to see if I was actually developing antibodies against COVID, because I'm prednisone, tacrolimus, Bactrim, zithromycin. There's quite a list of things I'm still on, partly because of the lung condition now. And slowly but surely they taper things off, but they can't quite go as fast as they want to now. Um, anyway, I had the antibody test, and I got a number of 529. And the antibodies that are the top number are 2,500. And so I have 20% of what full coverage um, looks like. So I am still more at risk than than a lot of people, I guess. So um, masking, absolutely. I try not to when I'm outside. I like the fresh air. But if I go into a store, any kind of a close situation, I have my mask at the ready always. Um, yeah.
Thank you. And we have a comment from our audience, and it says, really appreciate Nikki and Sean's openness and detail for sharing. Two of the most informative panelists I've heard. Thanks to both of them, and wishes for good continued health for them and for Sean's daughter. So I wanted to make
Yeah.
sure you guys knew that. Um, Last question for you guys. What best advice do you have for transplant patients who may be suffering from GvHD? And Sean, would you like to take that one first? What advice would you have for a newly diagnosed transplant patient with GvHD?
I guess take it seriously. Be aggressive if you need to. In terms of looking at treatment options with your doctors, because yeah, it's better to, if you can take care of it. I mean, hmm, yeah, I guess that would be it. Is just be aggressive about your pursuing treatment for any GvHD that you end up with.
Thank you, Sean. Nikki?
Yeah. Educate yourself. Watch the webinars from the AAMDS Society, and there's other places, the bmtinfonet.org. Watch them, either all or the ones that are most pointed towards you. But along with be aggressive is find a specialist in whatever GvHD you do have. Um, the sooner you can mitigate whatever issues you have, the sooner you will get some relief. Um, and I think if you catch things early, they won't get to a level that requires surgeries and more difficult interventions.
Thank you so much, Sean. Thank you so much, Nikki, for taking the time to share with us your experiences for patients who've had a transplant are now experiencing graft versus host disease. Your time today is so much appreciated by everyone. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any other questions, please feel free to submit them to us at any time. You can send them to our help account, which is help@aamds.org. You can give us a call. Our toll-free number is 747-2820, extension 2. And you can also submit a question to our Facebook page. I'd also like to remind everyone that registration is open for our summer patient and family conference. We will have transplant experts speaking about transplant and other things that may be helpful for transplant patients. And our conference is next Friday, which would be July the 16th and July the 17th. And our conference is virtual. And you can find more information about the conference and to register directly on our website, which is aamds.org. On behalf of the foundation, I'd like to thank you for making us your resource of choice and joining us today for this webinar. Our medical advisory board and team are always here to help you and your family, as we've done for the past 37 years. This concludes our program today. Thank you again, Nikki. Thank you again, Sean. Take care.
Thank you.